Okay. Do you think we can start, Marvee?
Yeah, I think we should be good.
Okay, sounds good. All right, hi everyone. Thank you so much for joining us today for our TNVIRJC Journal Club. We'll be talking about peripheral arterial disease today, interventions, and the imperial trial. So my name is Tulasi. I'm an M3 at OUWB, and I'm joined by my classmate Marvee, who's also an M3 at OUWB, and our wonderful faculty mentor, Dr. Dixit. Dr. Dixit, real quick introduction. He practices IR and DR at Beaumont Hospital in Michigan, and he completed his DR residency and IR fellowship at the Detroit Medical Center, Wayne State, and the Illinois Masonic Medical Center. And he has over 33 years of experience. So we're so lucky to be joined by him today. Thank you so much for being here, Dr. Dixit. So Marvee and I are going to basically go over the basics of PAD and the imperial trial. And then we're going to have a Q&A with Dr. Dixit at the end where you guys can ask him any questions about PAD or interventions or anything like that. So we're going to try to be pretty interactive with you guys and ask questions throughout our presentation. So if you guys could all join us on Slido right now, that would be awesome. The code is here, or you can scan through the QR code. And we have some intro questions to kick us off as well. So I think, yeah, so you can actually, here's the details over here to join. Some of you guys I recognize, like I said, Marvee, and Dr. Dixit are all from Michigan, so we'd love to know where you guys are joining us from. And if there's any new attendees or new members of the TNVIRJC, we are like a transnational IR journal club, so sometimes we do get people from other countries as well, like India, China, lots of other countries too. So cool. So we have some people from Chicago. Awesome. Yeah, one more person typing, so I'll wait. Nice, New York, cool. Okay, good mix. And then just to assess how familiar you guys are with peripheral arterial disease, whether it's like basic knowledge, like pathophysiology of it, or interventions, or just where you guys are at on it would be helpful to know. We're going to basically, Marvee's going to talk a lot about PAD, like pathophysiology and things like that, but it's a very broad, big topic. So we're going to basically touch on the basics of it. So wherever you guys are at in your background of it should be a good starting point. Okay, so again, the table of contents, Marvee's gonna go over the objectives and like anatomy, physiology of it. And then I'm gonna touch on the imperial trial and conclude with a Q&A with Dr. Dixit. So I'll let Marvee go ahead now with the objectives.
All right. Hi, everyone. Thanks again for joining us. So for this journal club, I'm going to start off by discussing really the basics of PAD. So we're going to talk about the etiology, risk factors of PAD, what it is, the anatomy and pathophysiology of it, as well as the clinical presentation, the natural course of the disease, and then we'll briefly touch base on the medical and the surgical management options for PAD, as well as some of the IR interventions that we do as well. And then lastly, Tulasi is going to go over the imperial trial. All right, so what is peripheral arterial disease? So peripheral arterial disease is basically the narrowing of arteries in the lower upper extremities. In this talk, we'll mainly be focusing on lower extremity PAD, as the article that we'll be discussing later on is based on lower extremity PAD. So in PAD, there's that chronic progressive atherosclerotic disease that leads to that partial or total occlusion of the peripheral vasculature. So in lower extremity PAD, it's characterized by stenosis and occlusion really anywhere from the aortoiliac segment to the pedal arteries. And there are many different diseases or disease processes that can cause obstruction in these vessels, but the vast majority of them are due to atherosclerosis. And oftentimes PAD also occurs concurrently with coronary artery disease and cerebrovascular disease. And lower PAD is also considered a cardiovascular equivalent. So also, because PAD results in reduces major organ blood flow, it causes that end organ ischemia. And in terms of the epidemiology of PAD, there are approximately 6.5 million people in the United States aged 40 years and older with PAD. And globally, the prevalence in 2015 was around 5.6%. So that's roughly around 236 million adults. And some of the risk factors that have been associated with PAD includes advanced age, smoking, diabetes, hypertension, high cholesterol levels, and elevated homocysteine levels. The excess homocysteine is thought to lead to vessel thickening, stenosis, and thrombosis. That's why it leads to that occlusion. But of all of these risk factors, smoking is actually associated with the highest risk of PAD development. And some studies have shown a fourfold higher risk of developing PAD in smokers compared to non-smokers. All right, so in terms of the pathophysiology of PAD, so initially you have the occlusion of the vessel. So that ischemic limb tries to compensate and resolve that hypoxia by inducing a lot of macrovascular and microvascular adaptations. And so it tries to promote angiogenesis via VEGF and the hypoxia-inducible factor 1 alpha. But then as the severity of the hypoxia increases as you move from the left to the right of this diagram, these adaptations are not able to compensate, and that eventually leads to that mitochondrial injury and free radical formation, as well as chronic inflammation, and eventually it leads to that muscle fiber damage. So all of these changes eventually leads to that decreased oxygen supply and increased metabolic demands, whereby you start getting symptoms of breast pain, chronic non-healing wounds, and gangrene. Sometimes even worse, can lead to amputation. So this is just a little review of anatomy of the lower vasculature. So as you can see, I don't know, Tulasi, if you can like point to the common iliac artery there, you can see that it divides off the external iliac and the internal iliac arteries. And then your external iliac is going to turn into your femoral artery. I'm not going to go through the whole anatomy of it just for the time purposes, but really the main purpose of this slide is just how important anatomy plays in determining the types of symptoms that patients will get depending on the location of the occlusion. And it's also important to remember that the internal iliac arteries also supply the pelvic organs, as you can see on the diagrams on the right there. So in terms of the clinical presentation of PAD, more than 50% of patients with PAD are actually asymptomatic. However, when patients do experience symptoms of PAD, it's usually secondary to supply and demand mismatch. So the classic presentation of PAD is intermittent claudication, where the patient will experience reproducible discomfort in a specific group of muscle, depending on where the occlusion is. And then that discomfort is typically induced by exercise, but then it gets relieved by rest. And the severity of claudication obviously depends on the degree of the obstruction, the collateral vascular channels that have formed, and how if they're able to compensate for that occlusion, as well as obviously the vigor of the exercise. And again, the symptoms can vary depending on the location of the occlusion. So this is where the anatomy comes into play. So for instance, if you have an aortoiliac disease, most patients may experience buttock or hip claudication. And there's also something called Lurick syndrome, where patients can present with the triad of claudication, erectile dysfunction, and absence of the femoral pulses. And then in terms of femoral disease, that can lead to thigh claudication, whereas in superficial femoral or popliteal disease, usually patients will typically present with calf claudication. And then sometimes patients can experience atypical symptoms due to comorbid conditions that can alter their perception of pain. And if there is a severe decrease in perfusion, that can result in ischemic rest pain. Also, some patients can experience severe diffuse pain, which makes you think of something like a diffuse acute limb ischemia, which is characterized by those 6 Ps, the pain, pallor, paresthesia, paralysis, pulses, and poikilothermia. And then oftentimes patients can also have non-healing wounds, ulceration, or gangrene if there's not sufficient blood supply. So we're going to do a little bit of a quiz here. Just a little bit on the anatomy. So you have a 54-year-old male with a past medical history of hypertension and hyperlipidemia, presenting with cramping in his thighs that's worse with exercise for the past 2 months. And he has also been having difficulty sustaining an erection. And on physical exam, you also note decreased femoral pulses bilaterally. So which artery is most likely affected?
And if you guys want, you can just type it in the chat too, or unmute yourself and say if you don't want to go on to Slido and type it.
Awesome. Thanks, Marley. Oh, hey, Marley. It's good to see you here. Yeah, so definitely the aortoiliac artery. So as we were reviewing in the anatomy, remember that internal iliac artery is going to supply the pelvic organs, and that includes the penis. So that's what's causing the difficulty in sustaining the erection, and then the decrease in the femoral pulses bilaterally as well. Awesome. All right, so in terms of the diagnosis of PAD, so it's really based on the combination of risk factors based on the history, the symptoms of PAD, and then the physical exam findings that are suggestive of PAD. And the ankle brachial index, or the ABI, is typically used to aid in the diagnosis of PAD. So usually the resting ABI is obtained by measuring the systolic blood pressures of both arms, so the brachial arteries, and then the ankles as well. So your dorsalis pedis and then your posterior tibial arteries. And usually you use the Doppler device. And then the ABI in each leg is calculated by dividing the higher number of the dorsalis pedis or the posterior tibial pressure by the higher of either the right or the left arm blood pressure. So you can see the algorithm here on the screen. So if your ABI is less than 0.90, that supports the diagnosis of PAD. But then if your ABI is between 0.91 to 0.99, so if it's borderline, then the patient may have PAD and they should undergo exercise ABI if you have a high clinical suspicion of PAD. Any values greater than 1.40 indicate that the arteries were not able to be compressed. Sometimes you'll see that in people with diabetes or advanced chronic kidney disease. But in the setting of non-compressible ABI values, so greater than 1.40, you can also do something called a TBI, or a toe brachial index. And if that's abnormal or less than 0.0 or 0.7, excuse me, then you can also do advanced imaging studies to diagnose PAD if your clinical suspicion is significant. So this diagram is just talking about the natural history of PAD. So at 5 years following the diagnosis of PAD, 70 to 80% have stable claudication. And then 10 to 20% can have worsening claudication that may require revascularization. And on the right side of the image there, you have the critical limb ischemia, which is a severe manifestation of PAD that can present as an initial diagnosis of PAD in about 1 to 2% of patients. And CLI is usually associated with significant mortality and morbidity. And at 1 year after the diagnosis of CLI, approximately 25% of patients may require amputation. And then you also have the 20% of patients with PAD that can have myocardial infarction or stroke within 5 years after the diagnosis of PAD. So really, PAD is associated with an increased risk of death, mostly from cardiovascular causes. So the management of PAD is really aimed at reducing the major adverse limb events or the major adverse cardiovascular events. So the initial treatment regimen includes cardiovascular risk reduction. So that includes your smoking cessation, diet modification, and exercise therapy. And smoking cessation has been shown to lower the risk of critical limb ischemia, amputation, and death. And in terms of exercise therapy, that can include either a treadmill exercise or walking. And in general, the exercise should be performed for about 30 to 45 minutes, at least 3 times per week, usually for a minimum of 12 weeks. And the American Heart Association also recommends reaching an intensity that induces claudication within about 3 to 5 minutes. And then in terms of your pharmacological therapy, you definitely want to control the cholesterol level. So you have your lipid-lowering agents like your statins, your ezetimibe, and your PCSK9 inhibitors. And a lot of studies have shown that higher intensity statins confer a stronger benefit compared to lower intensity statins. And then in terms of antihypertensives, there's no single antihypertensive strategy that's been proven to be superior, but the HOPE trial has demonstrated that ACE inhibitors have the strongest evidence of reducing major adverse cardiovascular events compared to other antihypertensive. And then you can also use ARBs as an alternative to ACE inhibitors. And then your antiplatelets, really the main indication for that is more for secondary prevention of coronary heart disease and stroke. And then you have your Calistasol, which is more for symptomatic treatment of claudication that's refractory to exercise therapy. So this is just an example of percutaneous revascularization that that we can do to alleviate that blockage. So typically you'd want to establish your vascular access first, and usually the contralateral common femoral artery is used for aortoiliac and infrainguinal endovascular intervention. So the patient undergoes the catheterization and sheath placement close to the target, and then after placement of the sheath, you'd want to get an arteriography to identify the target vessel, and then pretty much like provide a baseline of the distal circulation prior to the intervention. And then once your access is obtained, you anticoagulate the patient with heparin, and then you cross the lesion with a wire, and then that's when you do the intervention with a femoral popliteal angioplasty. So you can see the diagram on the right here, the before and the after angioplasty of the left superficial femoral and the popliteal vessels. So you can see that after the intervention, you can see that blood flow pretty open there. All right. And then in terms of treatment options, there's certainly a lot of different ways that you can approach the treatment. So you have your balloon angioplasty versus your stents, and I just listed a couple of the example ones here, and Tulasi will go into more details with regards to the trial as well. And then in terms of your post-interventional management, really the lifestyle modification and cardiovascular risk reduction are still key. So again, that means smoking cessation, optimizing your medical management of comorbid conditions like hypertension and diabetes. And then in terms of antiplatelet therapy, aspirin and Plavix have been recommended for about 1 to 3 months, followed by lifelong aspirin. And then in terms of statin therapy, the American Heart Association also recommends moderate intensity statin therapy for those greater than the age of 75 years old with PAD, and then high intensity statin for those less than the age of 75 with PAD. And then these are just some of the post-procedural complications that we can get with the intervention. So you can get a hematoma, thrombosis, embolism just from the manipulation of the artery. We can also have arterial dissection or perforation, and then lastly, contrast nephrotoxicity just from the contrast that we use during the procedure.
Okay, so now shifting gears into talking about the IMPERIAL trial, which is one of the most recent landmark trials in PAD. The trial actually started in 2015. Prelim results came out in 2017, and it received FDA approval in 2019, and the trial actually just completed in April of this year, so it's very new. Before the trial, what we actually knew was that we knew that drug-eluting stents and drug-coated balloons both separately improved patency and reintervention rates versus other older endovascular therapies that did not have paclitaxel coating on them. And we also knew that prior clinical studies typically compared the intervention, like an experimental drug-eluting stent, to a conventional PTA control, which is a percutaneous transluminal angioplasty, but there was never a randomized control trial that compared devices of the same treatment class, such as two drug-coated or drug-eluting stents. So the purpose of the IMPERIAL trial was to compare the safety and efficacy of two different stents, one being the Eluvia polymer-coated paclitaxel eluting with the Zilver PTX, which is polymer-free and also paclitaxel coated, specifically for the treatment of femoropopliteal artery segment lesions. So Marvee discussed that PAD is very vast. It can involve any artery in the body, but the IMPERIAL trial specifically focused on femoropopliteal artery segments because it's one of the most common PAD occlusion sites. So like it says here, Eluvia was a Boston Scientific stent and Zilver is by Cook Medical. So here's just a chart comparing the two. So the Zilver stent by Cook Medical actually received FDA approval in 2012, and then the Eluvia was a newer, it received approval in 2019 once the results of the IMPERIAL trial came out. So they both are nitinol based, both have paclitaxel coating on them in different dosages. But the main difference here is the polymer, since Eluvia has a polymer coating on it, but the Zilver does not. So because there's no polymer on the Zilver PTX stent, the paclitaxel is delivered pretty immediately, which I'll show you more about in a graph later on. But otherwise, they are both self-expanding and similar in size as well. And just to drive home the point, Eluvia is the one that elutes drug constantly while it's in the artery, and the Zilver PTX is simply coated in paclitaxel. It doesn't constantly elute the drug. So the clinical question that the IMPERIAL trial wanted to answer was, does a drug-eluting stent with sustained drug release improve patency compared to a drug-coated stent? Briefly about the study design, the study was a 2-to-1 randomized clinical trial, single blind. There were 465 participants from pretty much all over the world. It was a pretty global study at 75 study centers, including the USA, Canada, the European Union, Japan, New Zealand. And since it was a 2-to-1 study, there were twice as many participants in the Eluvia arm, 309, and then the Zilver had 156. So the way they measured efficacy and safety are listed here. Their efficacy measurement was a measure of primary vessel patency, which was assessed by duplex ultrasound at 12 months post-procedure. And then they measured safety by a major adverse event rate, which was defined at any cause of death through 1 month after receiving the stent, or target major limb amputation through 12 months, or target lesion revascularization through 12 months. Inclusion and exclusion criteria for the participants of the trial. So in order to be included in the trial, patients had to have clinical symptoms in Rutherford category 2, 3, or 4. And I will show you the Rutherford categories on the next slide as a refresher. They had to have lesions in the native SFA and or proximal popliteal artery. Stenosis had to be greater than or equal to 70%, and the vessel diameter had to be between 4 to 6 millimeters, and the total lesion length had to be between 30 and 140 millimeters. Exclusion criteria, if the patients had their target lesion or vessel previously treated with a drug-coated balloon or previously stented within the year, then they were excluded. If they had prior surgery of that artery in the target limb, they were excluded. And they were also excluded if there were on any, if they had any atherectomies or laser or debulking devices or dialysis. So this is a summary of the Rutherford classification. It's basically an objective way to label patients' symptoms. So again, the trial included patients who had 2, 3, or 4 classification categories. So this is moderate or severe claudication and ischemic rest pain. So quick comprehension quiz, if you guys can type in the chat or use Slido. How did the Imperial investigators measure the efficacy of the interventions? So did they look at death within 1 month post-procedure, or primary vessel patency at 12 months, or clinical symptom improvement using the Rutherford classification, or major limb amputation within 12 months post-procedure? Nice, yes. So the right answer is primary vessel patency. That's basically how they looked at, is the stent efficient or not? Is the stent doing what it's supposed to be doing, which is opening the vessel? Clinical symptom improvement is how the investigators assessed clinical improvement. So that wasn't an efficacy measure, but basically it's used to objectively assess patients' clinical symptom improvements. So this is the graph that I said I would touch on for the difference between how the 2 stents elute drug. So the Zilver PTX paclitaxel is the white line. And as you can see, the concentration in the tissue is quite large in the beginning when nearer to when the stent was deployed, but then dropped significantly after 60 to 90 days, as opposed to Eluvia, which is the blue line. The purpose of the Eluvia was to elute the drug longer over the course of the year, which matches this restenosis timeline. So you can see the drug is constantly eluting throughout the year, even though it has a lower tissue concentration of the drug initially. And here's some OCT histology shown in the animal models in the preclinical studies. So this first 2 columns is the Eluvia stent, so a drug-eluting stent, and then the last 2 columns is the Zilver stent. And we can see that the histology here shows effectiveness in the strategy of longer-term elution, essentially. So there's wider vessel patency in the drug-eluting stent here. So just to reiterate, Eluvia sustains paclitaxel release out to 1 year, as opposed to Zilver, which is more or less 2 to 3 months. And the Zilver PTX delivers paclitaxel rapidly with drug detectable in the tissue only through 2 months. So baseline patient characteristics of each arm, both Eluvia arm and the Zilver arm, they were really no differences, no significant differences in the age here or comorbidities, and also race was a pretty similar distribution. Baseline lesion characteristics are also similar for both arms. So if we mostly pay attention to the lesion length, the average lesion length for both stents were about 8.8 centimeters, or 8 centimeters for both. There was also over moderate to severe calcification in 2/3 of patients in both arms, so pretty equal distribution there. And there was also about 100% occlusion in 1/3 of patients in both arms. So it's relatively representative lesion characteristics in both arms as well. Now getting into the results of the trial, if we look at the primary vessel patency achieved at 12 months, remember that was the efficacy endpoint, we can see that Eluvia had primary patency of the primary patency of 86.8%, and the silver had 77.5%. So that's almost about a 10% advantage that the alluvia had over the silver. And if we look at safety outcomes, there was actually 50% fewer stent thrombosis in the alluvia arm, as well as 6 cases of positive remodeling in the alluvia arm. All with 6, on all of those 6 cases did not have any stent thrombosis as well. And all of these 6 cases also had their lesions were patent at 1 year. And now if we look at clinical outcomes, which is actually the most important thing for the patient, investigators used the Rutherford class distribution to assess objective symptom improvement. And we can see that there was an improvement from baseline out to 12 months, with over 80% of patients having none or mild symptoms, having basically none or minimal symptoms at 12 months in both the treatment arms, whether they received alluvia or the silver stent. So in summary, there was superior primary patency for the alluvia stent versus the silver stent at 12 months, about a 10% advantage. And there was also lower stent thrombosis rates for alluvia versus silver. And that was about 50% lower rates for alluvia. And then finally, there was significant symptomatic, functional, and hemodynamic improvement throughout 1 year in both the groups, but half the revascularization rate for alluvia. These are references, and thank you so much for listening. And we'll take questions now. Any questions you guys have for Dr. Dixit also, or if Dr. Dixit, you have anything to add about PAD or how we practice?
So, PAD as a practice has evolved a lot over the years. It has gone from the inpatient setting. It used to be like primarily hospital-based to being something that is, the vast majority is done in an outpatient office-based lab setting now. So that's one big change that has happened. The tools have multiplied exponentially. Earlier when the treatment of endovascular treatment of PAD began, we were just doing angioplasties, then stents came along. Now, as you have pointed out, there are drug-eluting stents, there are drug-eluting or drug-coated balloons, right? But other than that, there are various other recanalization tools, such as atherectomy. We didn't mention that. Atherectomy is a big component of revascularization. And atherectomy, what we do is essentially we just literally scrape off the plaque from the artery, and so that because the plaque is actually creating the stenosis. So if you remove the plaque, the hypothesis is, or the what follows is that the artery doesn't have to undergo any remodeling externally. It's all internal. And then if you line it with a stent, it stays open for a longer time. Okay. Instead of the plaque pressing on the stent and causing it to narrow slowly, or even though there's a stent, sometimes the plaque may release its lipids and cause thrombosis, right? That whole spectrum is taken out by atherectomy. Then we also have, talking about the approach, what are the approaches for treatment of lower extremity PAD, right? So Marvee talked about how we can come from above, contralateral approach. That was the old-fashioned conventional way, and we still do a lot of it that way. But now what has come up is retrograde access, pedal access, right? A lot of people will, with ultrasound guidance, actually enter the dorsalis pedis artery or the posterior tibial artery, and then make their way with a very skinny wire up backwards to recanalize occlusions. That has actually been found to be more, to have greater, success than coming from the top. That has something to do with the what is called the fibrin cap in these lesions, and the fibrin cap is easily penetrated from below rather than above. There are ways of directing yourself. If you were to go subintimal, let's say you went under with a wire, you went under the endothelium of the artery, then there are several new tools. New means, like they've shown up in the last 4 or 5 years, which are called re-entry devices, right? So you go up to a certain level subintimally. So you're going under the intima of the vessel, and then with the help of the device, we just pierce right through into the lumen of the vessel, right? So whatever angioplasty and stent placement you do is actually you're creating a new lumen underneath the endothelium. Okay, so that's another thing that we should know about when we treat PAD. There's a device that can actually show the interior of the vessel. It's like how we do endoluminal ultrasound, right? For veins. Similarly, we have for arteries too, which shows us the arterial wall from the inside. Where is the plaque? How much is the plaque? What is the characteristic of the plaque? And things like that by doing ultrasound loaded on a catheter tip, right? So these are all advances that have made the treatment of peripheral arterial disease completely turn it on its head. Before, earlier, exactly like Marvee said, that was what we did all the time. Okay, come from above. If you can cross the lumen with a wire, well and good, we do an angioplasty and stent placement. Otherwise, we just send them to surgery for a bypass, right? But now people are uncommonly going to surgery. They're not commonly. As much as possible, people will do endovascular treatment. So this is the new world of PAD. PAD, fortunately or unfortunately, fortunately for some physicians and surgeons, but unfortunately for the patients, is not going away. It is a constant what should I say, accompaniment of the modern lifestyle, right? The modern lifestyle, which is more or less sedentary, which includes a lot of processed foods, and is truly a huge contributor. And even though the battle against smoking and tobacco is ongoing, we still have people who smoke like chimneys, constantly doing that, and they are the ones who end up. We have had patients who, even though they have occlusion of their lower extremities and they're like in severe pain, but they still keep smoking, and I feel sorry for them, really, that they can't get away from it. So the treatment of PAD starts with a screening program. We used to have a screening program in Beaumont, which was essentially done by our vascular techs, our vascular technologists, in combination with the echocardiographers, right? Echo people. And what was done was that the patient would just have like these days, screening days. The patients come in, they actually it was out of pocket $70 for 7 things, $70 for 7 things. Okay. And this is how a screening program works. Patient comes in, pays $70, they get an echo, in which it's not a detailed echo. It's a kind of a cursory echo in which the tech can figure out the ejection fraction, any abnormal movement of the valves and stuff like that. But they don't go into detailed measurements and stuff like that. They don't do that. So a kind of a screening echo, and then there would be a screening lower extremity arterial Doppler. And then, of course, because they are also prone to venous disease, so a cursory lower extremity venous Doppler was thrown in. And then there were some lab tests, cholesterol and diabetes. So there were 7 things in that package, right? And that is how a screening program is supposed to work, you know? So people come in, they just pay that money and just get all these lovely things done. But all of them are somewhat cursory. They are not deep, okay? But once they detect something abnormal, then they will recommend to the patient that you need to get this thing done in more depth, right? Then, of course, the other source of PAD patients is from the primary care physicians, okay? Unfortunately, if you look across the country, and I may have told you before, both of you girls, that across the country, you can almost divide it 1/3, 1/3, 1/3. What you're seeing in the cities and the metro areas is that a lot of the PAD has been overrun by the surgeons and the cardiologists, right? And the IRs have a very small share left. And that is because the cardiologists and the surgeons in the cities and the metro areas don't have, there are too many of them, and they don't have enough work to do. You know what I mean? And so they start to act up and invade other areas. But if you were to go into small town America, then you will find that interventional radiologists are deeply involved in PAD. Okay, and that therefore across the country, the patient population is almost evenly split between the 3 specialties: 1/3 IR, 1/3 cardiology, 1/3 surgery. Okay. Other than that, your trial, the Imperial trial, was a great trial. I mean, I loved the way you presented it. It was very good. And Marvee, the anatomy part is also important, but you cannot go into too much detail, right? Like you said. But the fact is that the artery just continues down the leg and gives off branches, and the name changes. Like how we go down the street and the name changes, like as soon as I cross Canton, the same road is not called Canton Center Road, but called something else, Sheldon Center Road. It's the same road, right? So similarly, when you come down from the aorta, it's the aorta, then the common iliac artery that gives off the external and internal iliac artery. External continues down, common femoral artery, which gives rise to the profunda femoris artery and the superficial femoral artery, continues down, changes its name into the popliteal artery, and then divides into 2, anterior tibial artery and the tibioperoneal trunk. And the tibioperoneal trunk then divides into the peroneal artery and the posterior tibial artery. And then those 2, the peroneal artery ends at the ankle, it just stops there, doesn't go into the foot. But the AT and the PT, anterior tibial, posterior tibial, they go into the foot, and the anterior tibial continues as the dorsalis pedis, and the posterior tibial continues as the plantar arch. So that is just anatomy in brief, quick anatomy, rundown of what is what. And what else can I tell you guys? Tell me, any questions? Go ahead.
I have a couple questions. First, I wanted to thank the presenters. I thought the presentation in general was great, from, like you mentioned, Dr. Dixit, from the anatomy down through the trial. Really well done. My first question is for Dr. Dixit. So the study was promising for the Alluvia stents and the technology behind the continuous elution.
Yeah.
And this was a non-inferior trial for compared to Zilver. Does this trial change your current practice at all?
Not at all.
Specifically, with Zilver having current 5-year data,
Right.
does this trial change what you would do for your patients?
So, these trials are usually industry driven, right? As you know. And I don't know, but I suspect that this trial was probably driven by people from Boston Scientific, because they want to get a head up. But in reality, the practice doesn't change, because what we are really gunning for is clinical improvement, and which is very similar in both groups. Moreover, I know that the study lasted for 12 months. The endpoint was 12 months. But what we look at is a far longer, prospect. And we have found that it doesn't really matter, because a lot of these stents will require secondary intervention after about 2 years, between 1 and 2 years. We will have to go back again and fix them up, right? So as far as making a change in our practice, that's not going to happen. We're still we like Zilver PTX for their ease of deployment and their accuracy of deployment, and we're with them. It doesn't matter to us, because clinically the patients will stay disease-free for the same amount of time. What they are saying is that they've looked under the microscope and they have looked at the lesions. But what happens is, you have to understand, a lot of collateral circulation develops in PAD, okay? And oftentimes the collateral circulation actually helps the patient, stay symptom-free for a very long time. It's not just the stent, but it's also the amount of collaterals that are developing. And that collateral development comes from exercising and diet control and not smoking anymore. That's how the collaterals will be encouraged to open up. So in true reality, not a big change in the practice. Okay.
Awesome, thank you. And then the second question is just for Dr. Dixit and the group in general. One of the things that was mentioned in kind of the overall management before the trial was that our gold standard is preventing cardiovascular risk factors, and you mentioned the HOPE trial, as well as working on exercise therapy for claudication, and kind of bouncing off the concept that these patients are often fighting a battle against smoking and diabetes and medical follow-up. That exercise therapy that you mentioned was 3 times a week, inducing claudication for 30 minutes. How are we counseling these patients? Because that seems like a really huge ask of the patients, and I haven't seen a lot of success in clinic counseling these patients. And so either from Dr. Dixit or the group in general, I'm just curious what we're doing to promote success with that, because that seems like a really challenging task to ask our patients.
So I'll probably jump right in. So at Beaumont, we actually ran a trial where we gave these patients a monitor. It was essentially a little smartwatch that they were supposed to wear, but the smartwatch had an app in it with their consent, obviously with the patient's consent, and that app transmitted to the other end was this cardiac rehab specialist. He was receiving all this information about the number of steps they walked, the heart rate that they were reaching when they were walking, and stuff like that. A bunch of data from their smartwatch was being transmitted with their consent, of course, nothing without their consent, to the cardiac rehab specialist. And what he was doing was analyzing it and making sure that they were getting their exercise in. And if they were not getting their exercise in, then he would make a phone call, or he would start bringing them in to the office to get them exercise, right? So here's modern technology being fused with the need for exercising regularly. A lot of the patients have to be sent to, because they're obese as well, so they have to go to, we have a bariatric surgery program. Some of them were sent to the bariatric surgery program, and then exercise is a component of that whole bariatric surgery program. So that exercise comes in there. But truly, the one thing that they can do themselves, which they have such difficulty, is cessation of smoking. Very, very difficult to do, and has the most deleterious effects of all of these things. So that is we have psychological like therapy. We have all kinds of these weird therapies, where they even acupuncture for that matter and stuff like that. It's offered it's called the alternative medicine, or whatever it's called, integrative medicine. So they were trying to help these patients give up smoking with the help of all of these therapies. But truly, Jonas, the struggle is not with the exercise. They will walk. Everybody will walk. if they're coaxed along with a phone call or two, but the smoking part, they will sneak it somewhere or the other, and that's a big problem. So I don't know. I don't have the answer to how to get them to stop smoking. This is their own thought process. They have to come to terms with it and stop. It's like a sweet tooth. It's hard to give up sweets sometimes.
Sure.
Yep.
Thank you. I appreciate that.
Yep, no problem. Anybody else?
Yeah, actually, Dr. Dixit, hi, it's Marley. Thank you for the presentation, Tulasi and Marvee. And Dr. Dixit, I was curious about statin use with people with PAD, given the fact that they're already experiencing claudication at baseline, and then the possibility of myopathy on top of it as a side effect of a statin. Are there certain statins that are better to use specifically for people with PAD, or what has been your experience?
So statins have to be given. There is absolutely no escape from that. What you can do is you can add either coenzyme Q to make it more easily tolerated. You can also pick and choose between the statins. For example, simvastatin is a bad agent. It causes more pain. But there are some statins that, I forget the names, but there are some statins which are associated with less discomfort. But I'll tell you, Marley, that statins are probably the most easily accepted drug in this whole regimen. The myopathy does not play a role, especially when it comes to exercise tolerance. They tolerate exercise very well if they are coaxed along in a program where they're guided by an instructor. But yes, you're right about thinking of myopathy. I myself, have had terrible myopathy with statins. I take statin too, and I had to change my statin. I don't know which one I'm taking right now. I forget the name, but I had to switch out of simvastatin because it was just terrible. I would wake up even more hurting in the morning. So you're right to thinking about that, but I think that if they're in a guided program where they're like being gently coaxed along to do some exercise, they will tolerate that. But they have to take statins. This is like a must. And it has to be aggressive, especially if they're younger than 75. It has to be aggressive. Cannot be gentle. We try to drop their cholesterol level down below or around 100, that much, that aggressive. We have to be that aggressive. Yes, Marley, anything else?
Oh, great. Thank you.
So anything else, guys? It's getting a little late. Any questions? Quick. Let's go.
Hey, Dr. Dixit, thank you so much for the discussion. I just had a question about, antiplatelet therapy for patients with multiple stents versus a single stent. Does your protocol change at all?
No, it's the same thing. It's the same thing. One stent or multiple stents, the antiplatelet therapy remains the same. Aspirin for life and Plavix for, I would correct Marvee, I think it's 3 to 6 months. Okay, that's what we follow. Okay, Plavix for 3 to 6 months and aspirin for life.
Thank you so much.
Yep, no problem. So we are fortunate to have Tulasi and Marvee at Beaumont, and we have a very active collaboration with our vascular surgery department when it comes to the trainees. The trainees, they spend a lot of time, at least 2 or maybe 3 months in vascular surgery, and they're not just passersby. They're actually expected to do work, and I'll confess to you, sometimes the vascular surgeons even depend on them because they have far superior hand skills. I can tell you that the training programs that you eventually go to, you must always look for this collaborative kind of arrangement, because in the training programs, only a few, like for example, Rush in Chicago has a huge PAD practice, huge, man. I mean, it's massive. They're like doing more PAD than anybody else. but that is an aberration. That is not the usual. The usual has become, or the general pattern is that the level of PhD training in IR fellowships or training is less and less and less. But if you have that active collaboration with the vascular surgery people, you will learn a lot. There is no doubt about that. You always remember 100% of the time that your hand skills are way better than the vascular surgeons. They're no match to you. But when you meet them, you just try to sweet talk them. Never cross swords with them, right? But at the same time, they in their heart of hearts, they do appreciate the fact that you are better skilled. Right? They will never say that. They will die rather than say that. Okay. So, okay. Anything else?
Okay, well, awesome. Thank you so much, Dr. Dixit.
Okay.
If anybody has any other questions,
Any other questions, guys?
You can email us after. Thank you so much for being here.
Thank you.
Okay. Bye, everybody. Bye then.
Care.
Yep.
Bye.
Bye.
Thank you.